Hello, ladies and gentlemen. I would like to welcome you at our second session, which is devoted to quality in healthcare, understood as increasing the opportunities and chances for good health benefits. And I think that we'll be touching about some major issues relating to safety of patients. That's what our first presentation will be about. The second presentation will be given by a representative of the Outmit agency, by Dominik Dziurda. The next presentation will be about non-invasive medical ventilation and about creating departments for NIVM. That will be given by Dr. Czajkowska-Malinowska. And we will finish up with a fourth presentation about practical use of a registry, looking from the perspective of quality. The first presentation is about what is safety and quality in healthcare. So this will be a presentation given by Stanisław Iwańczyk, who is the plenipotentiary of the Director for Patient Safety at the Katowice Oncology Center. We are in the midst of developing and accepting the Act on Quality in Healthcare here in Poland. And now I am giving the floor to Stanisław Iwańczyk. Hello and welcome. My name is Stanisław Iwańczyk. I would like to thank you for this invitation, for inviting me to this session devoted to quality. I've also proposed adding the aspect of safety to this question. I am a laboratory diagnostician who has been the head of laboratory in the Katowice Center of Oncology, but over the 4 years, patient safety has become my passion and then also became an aspect of my work because 2 years ago I became the plenipotentiary for safety of our center. But I also tried to expand my horizons with regard to patient safety, and I try to share those experiences in Poland because the questions of patient safety are still not being given the right attention. I'm really stressed out about my presentation because I'm not really experienced with public speaking. But I think that even those cumbersome attempts on my part, the way I'm doing it is not the most important thing. The most important aspect is what is the essence of my subject, that is patient safety, where we could say that these are all actions which are to lead to a situation where patients who during a hospital stay or during receiving healthcare are harmed and which are experiencing severe complications, sometimes fatal, that the number of such patients is as small as possible, and to make sure that the tools and the experience available in the 21st century definitely make it possible to reduce that number. One more reflection. I think that 20 minutes is definitely not enough to present the huge area which is covered by those two issues, so safety and quality. But on the other hand, it might be sufficient to present a few important aspects related to safety and related to quality, which can be the cornerstone of a larger discussion. Because afterwards I hear that a discussion will also take place, but I think that it can also be the basis for taking very important steps for the quality of care and safety of patient care. Firstly, we have to think about what patient safety is. What does this actually mean? A little bit of history. The beginning of modern history of patient safety is associated with the publication of a report by Institute of Medicine in 1990. The report indicated that in the United States, as a result of adverse effects, 48 up to 98,000 people die every year. Because this report resonated in the media, many actions were taken with regard to research, which means that it was possible to identify the magnitude of those adverse events. And a lot of actions have been taken in the US and other countries to improve patient safety. It is worth to add that the basis for research which were used in this report was the work by Lucian Lepe, which was first published in 1994. So the patient safety movement, if we analyze the past 20 years, has been developing very intensely. What I would like to highlight is that this development is very diversified across countries, and countries such as the USA, Australia, Canada, Great Britain, and many countries of the EU are taking intense actions in this regard, but there are also countries where, in my opinion, and Poland is one of them, and this can be something we can discuss later on, where actions do not have a systemic character, systemic nature. They are only ad hoc actions or actions taken by local players. At the beginning of my slides, I am presenting a few definitions of patient safety. During my work with on patient safety, I have analyzed several dozens, or 29 to be precise, different definitions of patient safety published by renowned organizations dealing with healthcare. And I have noticed many discrepancies between such definitions. At the beginning, I decided to present a definition taken from Wikipedia, but it actually is quite a good presentation of patient safety. So patient safety is a discipline that emphasizes safety in healthcare by preventing, reducing, reporting, and analyzing errors and other types of unnecessary harm that often lead to adverse events in patients. Another definition is patient safety is the prevention of errors and adverse effects to patients associated with healthcare. That's by WHO. But I have a number of doubts with regard to the discrepancies between the definitions. And I was not the only one. Because numerous renowned people dealing with patient safety also had their doubts about the differences in those definitions. And in one of the articles titled "What exactly is patient safety?" they presented their own definition of patient safety, which focuses on two aspects: that patient safety is a discipline in the healthcare sector that applies safety science methods, and that is important because many actions of the patient safety movement are not evidence-based, and the inconsistent actions are not subject to analysis. And the other part of the definition is that the patient safety is an attribute of a healthcare system which minimizes adverse effects and maximizes recovery after such events. So It is also important to deal with the patient's suffering after such a damage has taken place and minimizing adverse effects and complications. Because of the many discrepancies between the different definitions, my reflections, personal reflections, have pushed me towards putting into question some definitions related to patient safety, because patient safety, as I've already mentioned, I found 29 different definitions. So the taxonomy is very non-uniform. Many actions have been taken to develop the terms, but they regard only aspects related to adverse, to the words used in adverse events. And I think that we should take a different approach, which I would like to share with you. So the term of safety in healthcare, I would replace patient safety, the term of the patient safety, which is limited. It is limited with regard to methods we can adopt to improve the safety. And we have the second aspect, which is associated with the entire environment in which the patient finds himself. So direct correlation of the patient's safety with the safety of healthcare professionals. This is particularly vital in the context of the pandemic, where the correlation between the safety of patient safety and the safety of healthcare professionals is very visible. I would also add that generally this is we need to adopt a holistic approach on all aspects of patient safety, and this should be towards revolutionizing patient safety. We should not only exchange patient safety and instead use healthcare safety, but we should adopt a systemic approach and first of all, we should focus on safety, that is, safety of the patient, which is associated with avoiding adverse effects, and safety too, that is analyzing all aspects of the healthcare activity system, analyzing the strengths, and improving those elements which help prevent incidents. In my understanding, patient safety in healthcare is a term which encompasses the patient, the visitors, the healthcare providers, all the players involved in providing healthcare. In an important book titled Still Not Safe, which is a critical analysis of patient safety, two authors, Robert Wills and Catherine Saplita, are posing a question: what will the future of patient safety be? And they are posing several questions and issues: bureaucracy, rebranding, and the fundamental change. I think a fundamental change is necessary. First of all, we have to approach a holistic perspective and take into account all aspects of this issue. Moving on to the next slide. With regard to the solutions that can be proposed in terms of reducing avoidable damage, some solutions that are to improve patients' situations. We have a number of actions which could be discussed in a lengthy manner, but I would like to focus on one aspect, which is of key importance, that is the culture of safety. The culture of safety is important in all other aspects taken as part of this movement towards reducing patient suffering. Because we should shift through the pathological culture where we are looking for people to blame for adverse events, for sweeping things under the rug. This is where I'm sure that in the Polish healthcare system there are some centers which are transparent about mistakes, but definitely the culture of sweeping mistakes under the rug is still present. Without taking up the challenge of creating the culture of safety, of safeguarding mental safety as well, we are unable to present specific actions in an effective manner. In my opinion, one example was taken by engineer Moda. We have 4 rules. The culture of assisting, help anyone you can. The culture of asking for help. If you don't know, ask questions, ask for help. Don't take on actions which you are not able to carry out successfully. So we are there together to create a team and save patient health. The third rule is asking younger people for help, because the more experienced ones might not necessarily be competent in all aspects. Very often younger people have a fresher perspective on how things are done. That's the third rule. And the fourth rule is the culture of listening. If someone is saying something, listen to him until the end, hear him out, because he might be saying things which might help save a human life. I am focusing a lot on patient safety, but moving on to quality in healthcare. Everyone knows quality as the degree in which healthcare services increase the chances of obtaining a desirable health outcome. I think that in the Polish healthcare we do not talk enough about various dimensions of quality. There are 6 of them. And if those 6 aspects are met, then we can talk about quality care. It should be safe, it should be effective, it should be patient-centered, it should be given in a timely manner, it should be effective and avoiding waste, and it should be fair. In the world, various indicators are used globally. Various patient safety indicators are used as an example of indicators safeguarding quality of care. Those indicators help hospitals and other healthcare organizations to monitor and follow the course of patient care. Here we have selected patient safety indicators. There are several dozens of such indicators developed by the Agency for Healthcare Research and Quality in the US. They regard various types of cases, for example, transfusion related indicators, delivery related indicators. So in specific fields, we should adopt specific indicators which have already been developed to improve patient care. The discussion in healthcare in Poland usually is about quality. Over the last 4 years, I was trying to push also on the idea of safety, not just quality. The question is, we cannot talk about quality without safeguarding safety. I know I don't have enough time to finish up, so I'll just be brief. In the world, there are two systems. The quality system and the safety system, they work together. They are overlapping and they are complementary to one another. So quality systems which are build a structure which allow specific details, which allow to avoid specific events. And my last reflections about what patient safety in Poland looks like. According to me, on this quality map, there are many shortcomings. First of all, the recommendations of the Council of Europe published in 2009 with regard to patient safety have not been implemented. But I would like to indicate some highlights, some good things. So we have engaged the Commissioner for Patient Rights, Bartłomiej Chmielowiec, to engage in the safety of patient care. And also we have managed to successfully engage the Minister of Health, Adam Niedzielski, into the creation of the Act on Healthcare Safety. So the strategy for healthcare for the future can be the first step to develop the quality and safety of patient. I will be very grateful for any comments or follow-up and feedback. You can reach me at this data seen on the slide. I think I didn't use too much of your time.
Thank you so much for your presentation. There are questions asked about safety. How do you perceive this in the context of the last 1.5 years and the COVID-19 pandemic? Also, what has become very important are hospital infections, COVID-19 among them. How do you assess this at the level of service providers? We're looking at legal solutions, but also at what we can do. So every stakeholder creating this system. So at the level of service providers, or drawing from your experience, what is improving in our thinking about safety? Madam President, let me phrase it this way. The experience drawn from the pandemic, and I'm talking about this on a personal level from my hospital experience, it was very difficult. The level to which different entities cope with this situation was the resultant of becoming involved in the quality of services delivered to patients. And this was the resultant of the last 10 years of what we have been doing. We had a team for hospital infections. We had a very dynamic person who could respond to this in conditions of limited resources. But of course, we experienced hospital infections as well. But these were limited thanks to the actions we took. I can't say we did this in advance. That would be an overstatement. But we reacted on a current basis. We trained our staff, and this was a continuous process. Despite limited options for contacting each other, we designed methods of communicating and agreeing on the things that should be done. And the things we failed at followed from the activities taken over the past years. In 2001, our hospital embarked on the ISO 9001 norm. And of course, this gave us some beneficial effects during the pandemic. But we have identified many areas where there's room for improvement, and we have to catch up with that. There was a lot of coherent actions, a lot of mutual support. Of course, that happened, but we are at a specific place, and everything depends on what had been done on the local level. What all of this done in the past influenced what happened during the present, and it also had an effect on the involvement of our staff. Thank you so much for your presentation. We will have more questions and more opportunities for discussion. Let me introduce the next presentation. We want to show you this year that a lot is happening at the level of service providers, and this time we will have a presentation on the national solutions. I invite Dominik Dziurda to discuss the guaranteed benefits package and on the quality of healthcare, and I hope that Mr. Dziurda will share some COVID-19 related experiences of the Polish HTA agency with us. So I hand over to him and enjoy the presentation. Madam President, thank you. Thank you for the invitation to this meeting. Quality, from our perspective, is a very broad definition. I believe that almost all analytical processes concern and stimulate certain areas connected with quality. All of this could fall under this umbrella term. In our work, we added one more concept, one more term. We are trying to deal with patient preferences. And I will discuss this in detail in a moment. This will be the third example I will discuss in my presentation. Just a very brief introduction to our approach to work, to analytical work. So depending on its level of complexity, on the quality of organizational structures, I want to show you three case studies, three examples. Technologies quality is explored to a great extent. And we had a lot of work, a lot of comprehensive work in this area. I will show you an interesting example concerned with bariatric care, a pilot project which entered into force in August, and the quality indicators we looked at under this bariatric care pilot project. I will also want to show you an oncological example and some comprehensive overarching recommendations, guidelines that the Polish HTA agency is working on. And the third example, some studies on patient preferences and including them into the processes of determining healthcare quality. So this is something we are working on. We are still working on the methodology of this work. Let us start with two slides which give us two different perspectives. In our work, we encounter these two perspectives, the perspective of the service provider and the patient. And we have to balance them to obtain a balanced situation and an equilibrium between them. I think that we are all aware that the perspective of the patient and the service provider is quite different, although they might have some common denominators. But very often these levels where a patient believes that the standard, the quality of healthcare is optimal might be very different from the organizational approach, because the patient is subjective, includes their own personal feelings, beliefs, and applies the principles of the socio-cultural system they live in, while the service provider adopts an objective approach. It would be perfect if these levels were identical, but this is not always the case. The other issue is the clinical approach and the organizational dimension. A lot of analytical work of the Polish HTA agency focuses on supplementing these areas. What we can see on the left side, so the diagnostic, the therapeutic path of the patient, to complete this with a safe and optimal services for the patient. But within the system, work is focused on coordination, on proper cooperation of service providers at different organizational levels to make sure that this path, which runs smoothly on the left side, runs smoothly. And the patient can pass through different levels in an optimal manner. Now, after I've presented these two perspectives, please look at our activity through this spectrum. Of course, about 30 years of work on drug and non-drug therapies. We have different levels. We have different targets and methodologies. We look at the therapeutic pathway of the patient, and the methodology used here are interviews with patients. In this slide, you have a sum up of what we've succeeded in recent years. In the system, we want to have a set of updated and current recommendations, and we want the quality standard of services to be sufficient. And also linking different levels of service provision, delegating tasks within a therapeutic pathway. We've come up with the concept for hematology and oncological care, and several comprehensive treatment pathways, which cover the whole process, so from the review of healthcare benefits through quality until coordination principles. We think this is important because we should add one more element on top of all the work we're doing now. We should also include the patient perspective in the implementation of all of these projects. And we get the impression that we should look further into this area. And just quickly, the system of quality indicators under the COSPAR pilot project. This pilot project was for comprehensive care, and it was designed by a team of experts cooperating with the Łazarski University. I am not the author of the concept itself, but then at the implementation stage of this system, so implementing the documents introducing the pilot project, the Polish HTA agency was entrusted with the task of looking into the feasibility of certain solutions proposed by the authors of this concept, and the Polish HTA had to translate this into ready systemic solutions. I won't go into the details, just in a nutshell. So comprehensive bariatric care, which covers the preparation for a bariatric procedure up to 6 months, between 3 and 6 months, and then after being released from hospital, up to 12 months of care, which should provide tangible healthcare benefits in a given patient. inclusion, qualification, criteria, place of implementation. You can read up on this in the details in the regulation of the Minister of Health. So how to assess the quality of bariatric care? We had two groups of quality indicators. One was connected with diagnostic, therapeutic, pre-surgery procedures, and others with dietary metabolic areas. So the question is, how can we combine these indicators into a system of indicators? How can we implement selected quality indicators into the system of rewarding service providers for delivering effective treatment? And in this slide, I've presented you with indicators which are in the author's report, so the proposed indicators. And to the right, you can see those which had been implemented. So I want to explain this change of attitude, why we decided to adjust this. So the first indicator is the median mortality. That's the third verse of the table. Initially, the authors, the team of experts, postulated that a low mortality surgery-related mortality should be achieved. So we need to improve the health condition of the patient and have a very rare incidence of death. And we should reward low mortality, and so use this to adjust the cost estimate of the service. Then we introduced the time of hospital stay. When discussing this with other experts, those who came up with the initial concept, we feared that if we made the financial rewards highly dependent on low mortality, for example, a hospital can perform 100 or more surgeries, so even one case of death would result in losing the whole potential funding, the whole pilot project. So we feared that introducing this requirement might have an adverse effect on patient selection. So the financial risk connected with qualifying a complex case or not qualifying a complex case is very high, because the hospital would not want to run the risk. The hospital would select patients where the clinical benefit would be obvious. Duration of hospitalization. In expert discussions, it was postulated that the hospital stay of bariatric patients was as short as possible. The preparation should be good, and hospitalization should not take longer than 3 days. And this was also a part of this adjustment criterion for the performance approach. And we succeeded in defining this indicator. Of course, our aim is to shorten the hospital stay. But we don't want the patient to come back within 14 days due to complications. So we combined these two elements, short hospital stay, but also ensuring that the patient will not have to be re-hospitalized within 14 days. And the third group of quality indicators concern bariatric care and long-term clinical effects. So we had to decide on how to reward the service provider if any positive clinical effects came about, so remission of asthma, remission of diabetes. And the clinicians, the service providers, arrived at the conclusion that grouping these parameters would be a good idea, because dividing them up, breaking them up into individual indicators, but including them in one group, and the adjusting indicator would be connected with the bariatric care indicator. So it would lead to both bariatric effect and a metabolic effect, and it would also be adjusted. So this is an example of a critical approach to how many really great indicators can be created to describe a specific system. But the question is, do these indicators really show that we're achieving the goal we want to achieve? And we have to be very prudent, very cautious to look at the figures, but also to see how these indicators translate into how the healthcare outcomes are changing. I also want to discuss the Polish HTA's agency's work on guidelines concerning quality management in therapeutic areas. For many, many years, the Polish HTA agency gives opinions on procedures concerning diagnosis and treatment. We have about over 50 such documents with recommendations on how to give opinions. And we also have a system of regulations and announcements of the Minister of Health. And there is also an announcement on the guidelines for giving opinions on diagnostic and therapeutic areas. It seems that the guidelines which the Polish HTA agency gets are adjusted, revised. We introduce certain changes, but the authors do not always agree with the changes we introduce, do not always accept them. Perhaps over time, they accept the changes and we can publish the guidelines. But the agency has taken efforts to increase its participation in creating guidelines and recommendations, and also supports the medical environment in creating such guidelines. We use Agree2, Adapti tools, and also under the Power project. Last month, we agreed on a methodology for drafting guidelines in oncology under the auspices of the Polish HTA agency and the National Institute of Oncology, and we hope that this will be published in the coming oncology journal issues. I want to say that the content of this consensus is not only in line with oncological guidelines. This consensus will set a standard for drafting guidelines and recommendations in Poland in all therapeutic areas, not just oncology. And the fourth area are the key recommendations on clinical procedures and organization. We are exploring this at the moment. I just want to underline that we are working on ready clinical guidelines and recommendations in the context of healthcare protection. This is an attempt to come up with key guidelines for organizations for clinical procedures in clinical areas. And this is the completion of the whole process of building the therapeutic pathway and creating its visualization. I can give you one example for this area are the key guidelines drafted together with experts on the basis of guidelines drafted by Professor Jakość and Professor Jasen on lung cancer. These are the key recommendations. Further on, we agreed on the key quality indicators for this clinical area, and then we finished this process of creating the pathway by assigning a minimal and optimal number of control points which can be monitored throughout the process. This is, I think everyone is aware of this, but it's difficult to implement that. The number of monitorable parameters should be as low as possible and should be used in areas where we actually await a feasible change. We are still conducting consultations with experts, but I hope that we will soon have the opportunity to implement this into practice to enhance the process of monitoring quality. And the last example I want to give you are the studies on patient preferences. So in line with the oncological strategy, our work is focused mainly on this area, and so it should be. But we see this as an additional but very crucial criterion for defining quality indicators of healthcare services. Last year, we finished the first stage of exploration studies of targeted interviews with about 100 patients, and next year we will have a quantitative study on a group of several hundreds patients and representatives of patient organizations. I started with this slide, and I would like to finish my presentation with this slide. The processes that we will be embarking on this year, let me just say what we are working on here. We are finishing work on cardiovascular diseases and rehabilitation, which has been on our agenda since 2016. So from the very outset of my term at the agency, this year we will be finishing off work in this area. And we hope that the studies which we are implementing now will translate into further projects, also involving patient preferences. Thank you.
Thank you for this comprehensive presentation of the work taken by the agency. I think that you've touched upon very interesting aspects with regard to comprehensive assessment in cooperation with the clinicians and also involving patients into the assessments. And we'll also be discussing in next sessions about how the UK is doing it. I have a question regarding the guaranteed benefits package that I want to ask you. A lot of works are taken with regards to implementing pilot projects or comprehensive care. What we are observing in Poland and what is important from the point of view of quality, one of the examples of creating comprehensive care is the program for treating stroke patients. So myocardial infarction patients. This is not the dominant program in the system, which is actually a shame because the results shown on the small sample of patients covered by Kozawał, so program carried out on patients with an MI. How is the agency working with the Ministry of Health to monitor the access to treatment with regards to geographical differences? The subject you mentioned regards mostly pilot projects, so projects with a limited scope. Indeed, the program you mentioned about myocardial infarction have great results. However, very few patients actually get to benefit from this program. I think that the good solutions which are proven, the question is, should they actually be in the form of a pilot program? Because actually the assumptions of this pilot project could apply to the entire population. So maybe there were some organizational hiccups, but basically this pilot program actually encompasses almost all different various healthcare institutions. So in theory, all patients in Poland can benefit from it. When it comes to such a pilot project, it could be this research vehicle that could compare 2 or 3 mechanisms, and they should by nature be carried out on a small scale. And then later on they could be introduced to the guaranteed benefits package. So we are talking about two different problems. We are talking about small populations, for example, the bariatric population. Are you working with the Ministry of Health to scale up pilot projects, to implement them into the system on a regular basis? Because we have had similar pilot projects like the one regarding thrombectomy. How can we, on the basis of pilot projects, where we collect data on effectiveness, how can we analyze what was achieved? Are you monitoring the effects, and can you synthesize the data and draw conclusions based on the new proposals? When it comes to ongoing insight, we don't have that, but we will be participating in the evaluation of the program after it has been finalized. So the key to the success is for the pilot project to be designed as a research project with specific outcomes, so that at the very beginning, when starting the implementations, we know what happens when we get these results or those results. So we will know straight away whether a solution works or not. We should avoid implementing solutions and calling them pilot projects which have not been designed as a research exercise. So all the pilot projects in which we participate are this paraclinical exercise which will allow us to draw specific conclusions in evaluation. Thank you very much. I am counting on more discussions because we have many pilot projects. One of the ones that are the most raises most emotions is the one regarding cancer care, which the pandemic showed us is particularly important with regard to access to care. Thank you for your presentation. And now I would like to invite you to another presentation. It regards non-invasive ventilation program in Poland. We are counting on the experience and expertise of Małgorzata Czajkowska-Malinowska, who is the head of the Department of Pulmonary Diseases and Respiratory Failure with NIV unit and Sleep Disorders unit, who is also the head of COPD and Respiratory Failure Center at the Kujawian and Pomeranian Pulmonology Center in Bydgoszcz. Hello, welcome, and I would like to invite everyone to see the presentation. Hello, ladies and gentlemen. Yes, we can hear you very well. First of all, thank you for this invitation. I'm really happy that at this session, which regards safety and quality, you have found place for my topic. I would like to present several aspects of whether treatment of people with respiratory failure was up to the relevant standards and up to the global standards, and whether the program which was implemented, so the program of non-invasive mechanical ventilation, was effective, what barriers we came across, and was the project successful. Invasive ventilation, invasive mechanical ventilation, has been used for many years in ICUs, but over the last 30 years, non-invasive ventilation was also being developed, which is also used at ICUs and in different departments. Ventilation which is less invasive for the patient. You can see a comparison. Two different patients who are plugged into the same ventilators. They have the same circuits connecting the patient to the ventilator, with one important difference. To the left, we have an intubated patient who has to be sedated, who has to be put into a coma. And on the right side, you can see a patient who was subjected to non-invasive ventilation, who has a mask which is tightly sealed to his face, and it is connected to the ventilator. So, first of all, intubation is not required. The patient is awake, does not need to be sedated, can have contact with the environment, can have a short break in the ventilation and eat a meal personally. And this type of ventilation is safer and associated with fewer complications. The first research was on non-invasive innovation was published in 1975, and it compared the two methods, and it clearly showed that the use of non-invasive ventilation reduces the risk of ventilation and reduces the hospital stay length. After that, other research was carried out, which were put into a meta-analysis published in 2003, and it was carried out on the data from 758 patients, and it showed that the mortality dropped by almost 50%, the risk of intubation dropped by 42%, the number of any complications was reduced by 62%, and the length of hospital stay was reduced by 3.2 days on average. So when we look at the risk of failure of therapy like death or the need for intubation, that was reduced by around 50% thanks to the use of the non-invasive technology. An analysis carried out in the United States on 7.5 million patients admitted to hospitals because of exacerbations of COPD has shown that the number of patients with an NIV was increased from 1% to 4.5%. At the same time, the percentage of patients who had to undergo invasive ventilation was reduced by 42%. So basically, non-invasive ventilation became the first choice method selected. Another study shows a comparison between the use of invasive and non-invasive methods, and this study also shows that the use of non-invasive ventilations reduces the risk of hospital-acquired pneumonia, reduces in-hospital mortality, and also reduces the cost of treatment by around 30%. Compared to invasive ventilation methods. So for this method to be successful with regard to safety and quality, it is necessary to monitor this aspect very strictly. That was observed by the Italians, who for many years were creating units which were intended for moderate care, something between invasive and non-invasive. An analysis has shown that this development of such unit is not uniform, but they have managed to develop guidelines for care on severe patients, starting with general departments and ending with ICUs. And we clearly see that the effectiveness of this therapy depends on the number of healthcare professionals in charge of the care over that patients. So this care is more intensive in this moderate care units than in the case of general units, but there are less healthcare professionals involved than in the ICU. And was the care in Poland with regards to treating exacerbations in COPD up to code in Poland? This is a study carried out thanks to the initiatives of the European Respiratory Society. It was an audit carried out in 2009, and it covered many European countries and assessed the access of ICUs to patients with exacerbation of COPD patients. So Poland was had one of the lowest access to ICUs for those patients. When we look at countries who treat 100 patients with COPD exacerbation in the ICUs, we can see a huge contrast. Actually, the practical access of patients with COPD exacerbation to ICUs was even lower because only clinical universities took part in this survey. A study carried out by Professor Kibler on the use of non-invasive ventilation method in patients indicates that this method is not used in ICUs at all in Poland. So we have various priorities used when it comes to admitting people to ICU. So exacerbation of COPD, patients with that really don't have access to effective treatment based on that data. We carried out a survey on the use of non-invasive ventilation, and you can see that only 2% of people with this disease have access to non-invasive ventilation at the level of municipal hospitals. At the level of regional hospitals, that percent was 23%. In total, only 15% of hospitals used non-invasive ventilation for people with exacerbation of COPD. So accessibility of this method was definitely not comprehensive, not full. Cooperation with the Ministry of Health has led to introducing treating non-invasive ventilation in adult patients to the guaranteed benefits package. That happened in 2013 by way of regulation. So specific criteria have been determined. What parameters need to be met for patients to be covered by non-invasive ventilation, and which units, which departments should handle such patients. It was a very good development which opened the door for using this method in Poland. But why did we actually want to create special rooms for non-invasive ventilation? Why did we need a special program for that? It's because we didn't have those moderate intensity care units. It's not enough to introduce the equipment, the medical devices, and leave it at that. This is shown by an audit made by the British in 2013, where non-invasive ventilation was very ubiquitous. It was used by as many as 91% of patients who required ventilation, but it was in the general units, not ICU units. So as many as 43% of this group actually had parameters which would suggest the use of the invasive method, but only 3% of the patients were actually intubated. So it's no wonder that the mortality of those patients was 40%, which was very high. In 2016, guidelines have been published by United Kingdom Society with regard to ventilatory management of acute hypercapic respiratory failure in adults. This standard clearly indicates that to improve accessibility of patients for patients with hypercapic respiratory failure, 2 up to 4 bed rooms should be created, which should be this moderate intensity care with increased surveillance, and we should have 1 such room per 1/4 million of the population. When we translate it to Polish realities, we should have 150 non-invasive ventilation rooms, which would have a total of 600 beds. So 300 up to 600 beds. Please look at the date. That was published in 2016, when the British recommended the introduction of such rooms. 2016 is exactly the year when we started introducing the program of non-invasive ventilation in Poland. What were the objectives of this project? Most of all, reducing mortality resulting from exacerbation of chronic respiratory failure, mostly COPD, but not only. Reducing the disproportions in access to non-invasive ventilation across Poland and compared to EU countries, and improving the treatment of patients with regard to exacerbation of COPD. It was a pilot project. We wanted to establish 55 rooms, and after managing the exacerbation, providing all patients with pulmonary rehabilitation. So it was also very important to create a nationwide database of patients with respiratory failure, which would be called POLVENT. It would help us assess the effectiveness of treatment and also to assess the efficacy and cost effectiveness of the adopted interventions. We also assessed the improvement of effectiveness of care, the possibilities of reducing the number of intubations, and the consequences of introducing pulmonary rehabilitation. We also looked at the project from the point of view of optimizing the costs for the public payer and also optimizing standards for continued care towards introducing a comprehensive care for patients. So did this program improve the health outcomes of the patient? Was it effective? First of all, did we manage to create the infrastructure? Over the course of 2 years, so the program was launched in 2016, 2017 and 18, we have managed to create 36 non-invasive ventilation rooms for 144 beds. We did not manage to create a single one in 3 out of 16 regions in Poland. 5% were in pulmonary care centers, and 5% was also in municipal hospitals. we also were able to determine that the beds were actually in use a lot. Like I've mentioned, we did not manage to create such rooms in 3 out of 16 regions, but the availability per average population was as presented at this slide. So that's the number of rooms per 500,000 patients. So we have created 36 rooms, and on the basis of the data we've obtained, we have calculated that we need to create 44 rooms more to achieve the total number of 80 rooms for non-invasive ventilation. The number of hospitalizations per 100,000 inhabitants also was correlated with the number of available pulmonologists, and here we have regional discrepancies. The patients were mainly patients with COPD, and it is important to note that patients had different severity scales of respiratory failure. So these were often patients with moderate respiratory acidosis, so usually they require ICU treatment. The endpoints, well, we had failure of the therapy, which was either death or the need for intubation. So when analyzing the inpatient mortality of patients in the Poland project, it was lower than based on various reviews. And thanks to the constant analysis of the effectiveness of the project, we assessed the mortality data for all admissions, whether that was to the ICU or the general unit. Mortality dropped in all types of admissions, and also the number of patients improved into the program and into the non-invasive ventilation increased. Also, the mortality of emergency cases dropped. Despite the rapid increase of the number of patients every year. It is also important to note that improvement in terms of mortality was obtained in all types of units, however, mostly in centers specializing in pulmonary care. Also, the number of patients at the ICUs was reduced. What were the barriers that we encountered? Most of all, various refurbishings and reconstructions in hospitals, which physically made it impossible to create such rooms. A lack of the required infrastructure. The vast majority of hospitals which treat exacerbations of COPD still don't have access to ICUs. Simply, hospitals like that don't have an ICU. Because the network of hospitals was introduced, many hospitals did not have pulmonology units. We also struggled with insufficient staff. And also, at the beginning of the project, the services were undervalued. First, the cooperation with the Agency for Health Technology Assessment, the valuation was increased in further years. What are the conclusions? So definitely the method of non-invasive ventilation became more popular and used to a greater degree. We have managed to achieve low mortality and low complication rate. And the project on rehabilitation, on pulmonary rehabilitation, also showed a significant improvement of the quality of life of the patients. Our recommendations include creating additional 44 non-invasive ventilation rooms and further development of the POLVENT database to allow for a long-term analysis of the effectiveness of the program. We also recommend comprehensive care over respiratory failure patients. So what did the POLVENT program bring about during the pandemic? Over the years, we have carried out, starting from 2016, 45 different courses of non-invasive ventilation. We have trained over 1,200 doctors and nurses. We have carried out 111 different training courses in hospitals. All these people who entered the pandemic after having been trained and after having experience in non-invasive ventilation and high-flow oxygen therapy. So they were very well prepped for the pandemic. All those units that we create took part also in treatment of people with respiratory failure during the COVID-19 pandemic. Is it worth to implement solutions introduced by POLVENT? It is our proposal that the program be continued, that more rooms are created, to allow us to continue clinical effectiveness assessments and also to include home care with regards to respiratory assistance. Thank you very much for your attention.
Thank you so much for a very interesting presentation. POLVENT is an example of a national program implemented by the Ministry of Health across the country during the pandemic and before the pandemic. I can see now, when we are experiencing already the fourth wave of the pandemic, are these solutions still in place? Are they becoming more effective? Is it easy to maintain this infrastructural basis created over the years? Yes, this is very important, especially in the context of treating COVID-19 patients. I'm afraid that the sound quality is very low again. The experience of the team we created has shown us something we have not experienced beforehand. The program should be implemented, and the pandemic showed us we need to develop this program. We need to follow up to continue, because this is a valuable source of information, especially for assessing the long-term outcomes of our actions. I would say this is a unique program on a global scale. Thank you, and we await information on the follow-up on this program. I hope that you, ladies and gentlemen, are involved in developing guidelines and standards, which is the basis for further thinking about patients, not just COVID-19 patients, but patients with different respiratory disorders. This is very important. Thank you for your presentation. I encourage our listeners and viewers to read up on this issue and to contact our speaker if you have any questions or comments. Ladies and gentlemen, we approach the last presentation of our session. It is on registers and on how to assess health outcomes. I invite Agnieszka Wojtecka from the Medical University of Gdańsk, from the Department of Public Health and Social Medicine. I hand over to you. Ladies and gentlemen, thank you for the invitation. In the case of assessing health outcomes on the basis of breast cancer registers, this is something we did at our department, at the Department of Public Health and Social Medicine. We looked at the scientific reports on what is being done across the globe. We looked at what is being done in the area of breast cancer registers. We wanted to see what the international activity looks like, what is being done in Poland, what could be implemented in Poland, what could be improved. Now, why breast cancer? Because this disease affects a very large population of women in the world. I have some figures from the WHO and from the National Register of Cancers. In 2020, more than 2 million of women were diagnosed with breast cancer across the globe, 18,500 of that in Poland. And we also have the figures on deaths caused by this disease. That's why it's good to look at not just the simple statistics on how many women were diagnosed, how many died from this cancer type. Registers can also give us the opportunity, as I will show in a moment, to measure other parameters and draw conclusions which will help us prevent arriving at such grave statistics and will help us improve the mortality rate. So registers of breast cancer as a tool for assessing health outcomes. The first example I want to share with you is a register kept by the University of Nebraska. And this is a register which has been kept for 10 years. The time perspective is a prospective one. Almost 5,000 patients. That's the actual number of patients registered, the number of actual participants. The goals of this register. So the goal was to create an online collective register for breast cancer and to collect historical data, medical data, family interviews, the data of biosamples collected in the centers which participated in this study in this register. And all of this was done among patients who had features of hereditary breast cancer. And this was combined with data already collected on patients with breast cancer. This was combined with data newly diagnosed with breast cancer. We standardized clinical data, community data, socio-demographic data. I will speak about the standards, the guidelines for standardizing the data later on, but let me just note that is what we did. And we did that to make it possible to draw the right conclusions. The right conclusions on breast cancer. And this specific registry concerned also other cancers. I speak about breast cancer, but that is just one of the cancers covered. And we also promoted and disseminated data on breast cancer so that we could outline a high-risk cohort for future studies on the molecular and biological basis of propensity for breast cancer and intervention trials. This register is still being kept and results will be published. What data was collected, what interventions were introduced, a review of the medical card, administering the questionnaire, a study of socioeconomic and demographic variables, but also collecting human biological tissue. And an important thing, evaluating quality of life in patients with breast cancer, so another endpoint to be measured. Participants of the study were also encouraged to individually complete an electronic survey or a hard copy paper survey. So they would provide demographic data, some personal medical history or family medical history. So all the endpoints, the family tree. And we also we also performed structured telephone interviews with the female patients. And what is important, the registry is still being kept and developed. We had advisors, coordinators of the study, and genetic advisors. So the goal was not just to identify the presence of the cancer and provide the most basic demographic data, but to provide more detailed data, to provide a basis for drawing conclusions on the needs connected with the treatment of the patients. And the participants of the study had the right to have insight into their documentation, pathology reports, and so on. And these would be updated on a regular basis. So after the treatment is finished, they still maintain contact in order to perform follow-up during a certain period. Another example of a breast cancer registry comes from Denmark. The Danish Breast Cancer Cooperative Group, the Danish Breast Cancer Cooperative Group was established by the Danish Surgical Society in 1976. And the online collection of data and the online implementation of an electronic database started in 2009. So this registry has a tradition which goes back a long time, and they are very well organized. What we regretted is that they don't have many publications on this in English. We hope to establish some cooperation, to develop cooperation with Denmark here to learn more about their register. Now, what this registry is doing is a quality assessment study. And what is important here are the prognostic and predictive factors. So the Danish cooperative group is implementing this. They're adding elements to this register and expanding it. Another big register, Denmark is a small country as compared with the US, very small in that context. What the US is doing about its registers. So the US practice is for hospitals to keep their own registers, for example, for breast cancer. Sorry, we have some technical interruptions here. They have specially educated and trained coders to do this. And they are capable of encoding a case of breast cancer and introducing it to a registry. Then this is reported to the central state-level registry. And then every year, the state registers send it to the CDC, so the Centers for Disease Control and Prevention, and that's a national-level database. And this program I'm presenting now is providing financial and technical support for these state-level registries. And this measures progress in treatment, in prevention of breast cancer, and of course it measures mortality. So this register puts these smaller state-level registers together, and this should all and with a final report, like an epidemiological or endpoint report, so something summing up all the smaller reports. So it shows any breast cancer trends over time, and this is also important because it has some guidelines on setting the priorities for allocating health resources to treatment and prevention of breast cancer. Starting from 1996, there is a software for processing data from medical facilities and registries, and these are of course compliant with national standards. I'm sorry, I think I skipped something here. So the practice in Poland. Data on cancer is collected in the National Cancer Register, which is independent from the public payer. And of course, data on cancer is also collected by the National Health Fund. And this is an example of a drug program for the treatment of breast cancer. This is the data we can obtain, the statistical data in this registry. But the question is, if we have general data on breast cancer, are we not missing something? Do we know how complete the collected data are? Is there something we don't know about patients suffering from breast cancer? Now, if we look at the US, we know that there are several sublayers in breast cancer, and the red line you can see in the graph, you can see that in the sublayer with a triple negative breast cancer, there is very high mortality. And how can we translate this into Polish data? How can we compare this since these patients in Poland are not covered by the drug program? What do we know about them? How do we provide healthcare to them? Are these data collected appropriately in the form of reports? Or is this just a dependency between the patient and her lead doctor? And that's where healthcare ends. So it's interesting to look at this, especially aggressive subtype of cancer, and we decided to look at this. There are such registers for triple negative breast cancer across the world, and such a registry can be used as a tool for assessing health outcomes. This is a register from the US, which is kept by the Medical Center of the Kansas University. The target period of observation is 10 years. And the basic indicator is the frequency of germline mutations, such as BRCA1 and 2, the response to chemotherapy, long-term survival indicators. So the point is to ensure the possibility of using such registries to develop new treatment technologies for such patients. And the inclusion criteria, of course, triple negative breast cancer, a patient who was diagnosed not more than 5 years before, or carriers of germline mutations. And the exclusion criteria, triple negative breast cancer, but the patient had been diagnosed more than 5 years ago, or some specific mutations which form an exclusion criterion. So for this specific subtype of breast cancer, there is a registry for Arabic countries which grouped together to create such a registry. Now, how can this be organized? How does the organization of databases what should it look like to provide us with detailed information. And we have literature of the field which provides us with such hints. Let me just give you some pointers here. The processes of designing databases and the steps you should take. So specifying the objective behind the database, selecting and organizing the required information, splitting up the information into the data. You should also decide who coordinates this and who is responsible for organizing the information in the database. So organizing a database and managing the data, this is what it should contain: demographic data, diagnosis. So these, and you should also use descriptors of these data, of the meta descriptors, common data elements, and the clinical data. What we call the clinical data should be divided into clinical CDEs, non-clinical CDEs, and research CDEs. I won't look into this in detail, but just look at the slides to see how many types of data we have: personal history, laboratory tests, diagnosis, observation of the patient, and also the non-clinical data, so demographics, identification data, contact details. And the last category, research data, so details of the trial, the type of the trial, the cohort, the clinical study, identification details of the trial. So just in short, and to conclude, maintaining registers is an indispensable element of providing quality care and a tool for achieving better, measurable health outcomes, something that we call value-based care at this moment. That's why we need these registries. But the structure of a registry, so the endpoints, should reflect the specific features of a given disease unit. If we have subtypes, and these subtypes have completely different endpoints, these should be included as well. And we can see that is happening across the globe from the international practices I've reviewed. Thank you very much.
Thank you for introducing the issue of registries on the example of breast cancers. We know that the program for developing registries also provides for the development of registries for specific body organs, and they are to be implemented by 2022. Now, when we look at the issues related to the actual usage of data in Poland, whether in a registry or not, what is your experience outside the central level, where we look at epidemiology, at the types of patients and access? Have you been observing the possibility of using the data by specific clinicians, by specific hospitals? Across the world, registries are carried out independently of the payer. And if we want to analyze data collected by the National Health Fund, they will be mostly data which are reported to settle the costs of the benefit. And we have a specific data set used for financial settlements. But if we want to maintain reliable registries which are independent from the payer, they should be adequately designed, and that planning should also provide for financing of such registry. So who will not only pay for setting up the register, but how will the people entering the data be remunerated? and whether the financing is there impacts the completeness of data, whether it is complete or not. Now, if we want to carry out an analysis, we can use data from the National Cancer Registry or take data from the National Health Fund and compare this data. I did it a few years ago, but this clearly shows that we have to uniform those databases. Cohesion is necessary because they are to help us find the answer to the question, do we need screening? Which groups of patients tend to contract different types of cancer? What is the survival rate? So finding answers to such questions. I can see we also have questions from the chat box. Unfortunately, we will not be able to answer them live here. Thank you for this fantastic presentation. I think we will be able to continue the discussion about access to data. I am a supporter of thinking about registries being close to clinical practice. So data becoming actual reality. We move data. We take the example of, let's say, IT companies which are developing management, which we also try to use as part of value-based healthcare. So using coordination of data management and communicating and analyzing the findings, also on a central level by the decision makers. Thank you. We are now wrapping up our second session. All those subjects are overlapping, and tomorrow during the presentation by Björn Wetterman, we will be discussing the compilation of registries in Sweden during the COVID-19 pandemic, and more data about the health status will be discussed at the session tomorrow about what the local governments are up to. So you are invited to our next sessions. The third session will regard SMA. It will be a satellite session sponsored by Novartis. We will be starting that at 1:40 p.m.